Hello, everyone. Welcome to Co-Produced Care and our live stream series. We have got so many fantastic live streams ready for you this year, and we're kicking off with a wonderful new one that we're going to be holding with a think tank. So Reform Think Tank, we're going to hear all about it, not affiliated with Reform, the party, I'm afraid, but actually some really incredible insights. And I'm really looking forward to speaking to Rosie Beacon, and she is going to be focusing on health and social care. A few wonderful discussions there, but a little bit of information about what's coming up this week. Actually, we're having 2 live streams this week. So I don't know if you heard on the news, but I was listening to Radio 4 this morning, the Today program, I think it is, and they were talking about the employment rights bill, and that's going through Parliament at the moment, and there's a lot of implications for social care, especially if we don't get the funding in order to meet the extra requirements, which are actually quite a good deal for care workers, around 0-hour contracts, around better terms and conditions. So we have invited James Sage, who some of you who follow our live streams will know that we have spoken to before in the past, and he is from employment law firm RWK Goodman, and he's going to talk to us a little bit about the employment rights bill, what you need to prepare for, and also the passage of legislation and how it passes through and when it might come into effect. So I think it's going to be next year, but there's a lot to potentially campaign for if we are going to be compliant with the law. So that's coming up on Friday, so in a few days' time. So make sure that you like and subscribe to make sure that you understand everything that you need to prepare for in terms of employment rights. But today we're going to be talking with Rosie. I'm going to bring her in a minute, but just so you can have a little bit of we're going to put in the chat some of their website, but Reform Think Tank is Britain's leading public services think tank. They're dedicated to advancing ideas to radically improve the functioning of the state. They want to transform. So we are all about transformation at Co-Produced Care. We want to know how people are thinking differently, thinking outside the box. And if you actually go through their website, if you click on the research tab at the top, you'll find that they've done quite a lot of research, everything from looking at health, but also how it intersects with social care, and how developments in health can support the social care sector and vice versa. So do check them out. There's tons of them there. I've just put up a few that you can find on their website, but we are going to be talking to Rosie a bit more about the work that they've done and the work that they're doing. So do tell a friend to come along and make sure that we can get some questions in the chat. I know a lot of you do listen after work or, after the live stream, but if you are tuning in live, then ask away in the comments box. And of course, if you want to be fully aware of everything that's going on with Co-Produced Care and all the live streams we've got coming up, then do like and subscribe. If you're on LinkedIn, make sure that you put comment, and if you're on YouTube, best place to be then to subscribe, and of course like this video. So without further ado, I'm going to bring Rosie in. Hello Rosie, how are you today?
I'm good, thanks. How are you?
Yeah, not too bad. I'm actually feeling quite bonny only because the sun has decided to come out, and we've got a little bit of spring in the air, and so yeah, no, not feeling too bad actually. It's nice to get rid of those winter blues. How are you?
Yeah, fairly similar. There's been a kind of a fairly jubilant vibe in the office with the lovely weather. So yeah, I mean, it's a shame. I mean, it's actually getting dark now, but for the majority of the day, it's been very sunny in the office, which has been delightful.
Oh, that's good. You've obviously got some good windows in your office. I love that. So I think we just need to understand at the offset, right at the start, who is Reform Think Tank? Maybe when you started and what you're all about.
Yeah, good question. So reform's existed for about 20 years, and it's always focused on public service reform. Throughout the years, we focused on all sorts from justice to health, and policing, welfare. And at the moment, we have three core work streams. These are health, obviously, which I work on,
Yeah.
Whitehall, which focuses on civil service reform, and local state, which focuses on, local government. Um, and the kind of underpinning kind of philosophy beneath all of three of our work streams and across all of our public service reform work is that the post-war public service settlement is no longer fit for purpose, and that that governments need to fundamentally reimagine their approach to public services for the 21st century. Um, to meet the needs of modern society, because they were designed for a post-war society and it no longer works just because society has changed so dramatically, demographically, economically, socially, culturally, that they no longer work the way that they should. And that's the kind of thesis underpinning the Reimagining Health programme too.
That's amazing. So, I want to talk about the Reimagining Healthcare as well in a bit more depth, that program you talked about, but also it'd be good to find out a little bit about you, how you got to working with reform, how long you've been with reform, where you were beforehand, and sort of what you want to achieve in this space.
Yeah, also a good question. So I've been in reform now for about a year and a half, and in that time we've done we're trying to work our way through the kind of major pillars of the health system with the Reimagining Health
Mm.
programme. So the kind of analytical framing, actually, we'll get into that in a second. More about me is before I worked at Reform, focusing on health policy, I worked at the Tony Blair Institute, focusing on general public service reform. TBI has a bigger focus on kind of the role of AI in public services. So I did a lot of work on that, but also just general public service reform. I was there during the pandemic. So I did a lot of work on vaccine passports, and a lot of the big questions about how you use data and digital identity in modern public services, which was really interesting. And I was there for 4 years. And then before that, I worked in banking and financial consulting for 2 years, which is completely different to both of the things I've already done. Both things I've done for the last 5 years. But it was a really valuable experience working in kind of a trading desk and an investment bank. But like I say, extremely different to stuff I do now.
It is, but also I went to a talk, I think it was at Care England a few years ago, and somebody was talking about how care can actually take inspiration from different industries in the way that we work and the way that we do things. And I think at the time someone was talking about aviation. So I think even when you have people from different industries that come into the care sector and do things like what you're doing, sort of in a think tank, just having those new perspectives, different perspectives, I think could be really helpful. And I suppose you're probably learning a lot about the social care in what you're doing as the system and how it works and what you're doing, because obviously you've not come from that background, and some people we interviewed have the social care background and they're trying to improve it from within, because we've been working in it in a while and we feel we know what's right for it. But coming into looking at health and social care, is there anything that you feel surprises you with what you have learned in your research at Reform?
It's a really good question. I suppose social care is like it's funny when we've spent obviously a lot of time analysing the NHS as an institution, and obviously in 1948 health and social care were split up and dealt with differently as kind of different services. And it's pretty remarkable delving into it, seeing how independently it operates from the rest of the system. And that it's kind of got all of its own independent problems that are kind of interrelated into the NHS, but it's almost like a completely separate operating model, which quite surprised me when I started working on it. I thought, yeah, every time I started doing a new NHS analysis, I started on structural reform of the NHS, then I moved on to primary care, then I moved on to secondary care. All of those things had problems that were interdependent with other parts of the system. So a problem in primary care was also a problem in hospital care, or a different version of it, and they were connected. Whereas you look at a lot of the problems in social care and they all happen independently in social care. Like a lot of them can't be tied back to the rest of the system. It's just its own organic thing that's kind of been left to fester for such a long time. Like I couldn't really believe how much of a separate system it was to the NHS, and consequently how many separate problems it has. Um, like I say, I think healthcare is a uniquely interdependent public service. Everything in healthcare is related to everything else in healthcare. But somehow there's something about social care that's kind of been left on the side for such a long time, which, yeah, really surprised me.
Absolutely. And I think you've got a good point there, which is kind of why we do this program, because we want to hear about what people are doing in the space and looking at health and social care, but we also want to give social care a platform. So great. So I wanted to go into a bit more depth in the projects that you're doing at the moment. I know you're doing everything from, or you have done, your area in Reform Think Tank has looked at hospitals and virtual wards, tech and social care, sort of sensors in people's homes, and that intersection between health and social care. Is there anything that you're working on at the moment that you want to sort of like delve into?
Yeah, I mean, just like, I mean, can I explain a bit more about the kind of analytical framing of a lot of our health papers? So generally, when we start a new piece of work in the health program, we will sit down and think, or at least we try to, what should, if we had to design the health system from scratch today, how would it look? Say it didn't exist already, how would it look? And then we kind of try and work back from that vision to something that you could plausibly implement today, or something that you could give a policymaker a recommendation for tomorrow, and it would help them create that kind of ideal system. And that's kind of what we've tried to do with a lot of the work that we've done. With the work on social care, so the minute you start working on hospitals, you also kind of start working on social care, because every chief executive you'll speak to in a hospital, or anyone in a hospital, will blame social care for something. It comes up, and to be fair, like it's not illegitimate to say that there's not enough capacity in social care, so therefore we can't discharge people. Like that is a legitimate concern, because sometimes they genuinely can't discharge people. But it's not as large a proportion as they make out. So there is a big question around why hospitals are slow to discharge. A lot of it doesn't come back to social care. There is a big gap between hospitals and social care that's really, really unproductive and massively undermines the patient experience, also undermines clinical effectiveness, cost effectiveness. But like you say, we've been doing a lot on virtual wards, which have a massive intersection with social care, because virtual wards are essentially the ability to provide inpatient hospital care in somebody's home, which is actually just an enhanced version of social care.
Before you go into that, I really want to explore that gap that you have seen in between, what hospitals are saying is the issue and what you perceive is actually the issue. So firstly, kind of, is there anything more that they're saying rather than, oh, there's just not enough capacity? That's the problem with social care, and also to explore that gap that you just mentioned.
So they will often cite social care in general as a reason for the patient flow in a hospital being bad. They won't necessarily specify what it is. It's usually that it takes a long time to sort out. So even if there's capacity, it's a lengthy bureaucratic process in order for the hospital to sort it out, and it takes up their time. And also there are a lot of discharge processes involved in getting someone out of a hospital. You have to write a discharge letter, and that has to be done by the doctor on the ward. There's like a lot of bureaucracy in addition to finding them suitable at-home care. I think the reason it's cited a lot is just because such a large portion of inpatients are frail patients who are almost guaranteed to need at least some sort of social care when they get home. It might not be long term, but they'll definitely need something. So there's that. I mean, and we did some analysis on this. Before I started, did some analysis on reasons for kind of long A&E wait times, which is essentially about how quickly you can get people through the hospital and out of the hospital. And the specific statistic, I will find it, but I think it was only about 24% of just delayed discharges were due to problems outside of the NHS's control. So actually quite a lot of it was to do with processes within the hospital, whether that was discharge management or actual management. In terms of the gap between hospitals and social care, the operational overlap between the hospital and social care and district nursing, for example, is significant, more so than kind of the operational overlap between social care and primary care, if I'm completely honest, because social care is often looking after the patients that are most likely to end up in hospital. And so the kind of in the Venn diagram of like the different types of patients going into hospital and going into social care, there are a lot of people in the middle of that Venn diagram between hospitals and social care. And so it's particularly noticeable when they don't work together that well, just because they have such an overlap in their patient demand. Like the kind of people using social care are much, much more likely to end up in hospital. So the kind of gap, I mean, it really varies depending on the locality as well. Different hospitals will experience different problems, different social care providers. But for example, with virtual wards, there's a really natural overlap between the work of a virtual ward and the work of social care. And yet virtual wards are run exclusively out of a hospital trust, almost operate completely independently from social care, when actually there's a huge potential to run virtual wards out of residential care homes. As in,
I kind of interrupted you when you started talking about virtual wards. So yeah, go back and kind of explain for anybody who doesn't know what they are again, what a virtual ward is. And then yes, please continue with this idea that you have that actually social care should be in the driving seat for it rather than the NHS.
So virtual wards are a form of hospital inpatient care, except the patient is being monitored remotely. So they'll have different tools used to monitor them, depending, it could be blood pressure, it could be, there are so many different types of monitors different hospitals use. And they'll set them up on the patient in the hospital and teach them how to use it, teach them how to measure themselves if they need to, and then send them on their way and they'll go home. They will also assess their home circumstances too. And then they will have permanently an office of, certain number of nurses, an emergency medicine doctor, a junior doctor running the virtual ward, and on their computer screens, they will have all of the kind of observations coming in from their patients in the virtual ward. And depending on the remote monitoring they use, they will get alerts when somebody's observations are anomalous, or when there's something that should be flagged to a doctor. It is flagged kind of actually proactively and automatically. But also they can instantaneously contact the nurses in the virtual ward should they need to, because it's permanently staffed, just like a normal ward would be. The benefit of this approach is that you need much less staff to provide exactly the same service. So like I say, they're still being, if anything, they're actually still being monitored. They're being monitored more continuously than they often are in a traditional hospital ward, but they're doing so within the space of their own home. The benefits of this are varied, particularly for frail patients. They decondition quite significantly in hospitals. They get quite delirious. A lot of evidence suggests they get much more sick being in a hospital setting. So if you can take them out of that setting and into their own home, they benefit quite significantly just from a clinical perspective. So there's that. It's significantly more cost efficient because you need less staff to do exactly the same thing. And the patient experience is pretty high when it's done well. And anyone watching that's got experience virtual wards may actually say, well, I've worked on a virtual ward, or I've seen one and it wasn't very good. There are a lot of virtual wards where the outcomes are quite variable because they're not implemented particularly consistently. They're usually run by the trust, which means there's tons of, I think there's like 200, I can't remember the exact number. I think it must be like 250 trusts in the UK. So they're all run completely differently, but where they're run well, they produce significantly better outcomes than a lot of traditional inpatient wards. So it's worth flagging that a virtual ward isn't just sending somebody home and monitoring them. It's providing the same level of hospital inpatient care, but just in the home, and remotely. So that's what a virtual ward is. In terms of the overlap with social care, there is so much potential to run these out of residential care homes, and to pay residential care homes running, like for having somebody that looks after the patient on a virtual ward. Like, especially if that person is at high risk of readmission, there is a huge benefit to doing this specifically in conjunction with a residential care home or a nursing home. That's not done as far as I'm aware, and if it is done, it's done in pockets where they've worked really hard to get off the ground. It's not a universal practice, but the potential is enormous, with the overlap with, especially if you're going to use virtual wards as a way to reduce your inpatient hospital capacity, which is essential if the health service is to become sustainable long term, like fiscally sustainable long term. So yeah, that's what virtual wards are. Oh, I can't hear you for some reason.
I've got 2 mute buttons, which isn't very helpful. Yeah, no, I don't actually know that much about virtual walls. I've never used them before, but I think one of the things that social care, well, a few providers that I know, we complain about is the fact that sometimes we are asked to do more work, which we would expect someone like a district nurse to do. And sometimes there's training, sometimes there isn't enough training from the NHS, but there's an expectation we're supposed to do more. And it seems like a good segue to formalize a type of system where we are trained and we are financially supported to do something like this.
Mm-hmm.
And of course, then there's positive benefits for people who need extra care. And it seems a little bit of a no-brainer, actually. Do you know? You might not know, but how much appetite there is to take forward your suggestion, or the idea of remunerating care homes and helping them to do more of this type of virtual ward work?
If the money is available, then I don't think there would be any opposition to it. What would need to happen is it would need to happen out through the ICS. It can't happen through a trust, because the trust is incentivized to spend that money on themselves. So you want to create the incentive, you want to give the money. If the money is going to be allocated towards virtual wards, you would ideally want to give it to somebody that sits above a hospital or doesn't run a hospital, because there are no financial incentives for them to give that to a residential care home. But I think if the money did go, for example, to an integrated care system rather than a trust, and a lot of time it does just go straight to trusts, even if it's given to ICS in the first instance, then you could easily do that. What we think there are so many kind of funding obstacles with virtual wards, because just like a lot of innovations in the NHS, the money is it's given quite sporadically, and it's not given long term. So it's quite difficult to plan long term for virtual wards, because they don't know how much longer they have the funding for, which means that they don't staff them properly, so that they hire locum staff instead of hiring permanent staff, because they don't know how long, which is significantly more expensive. It's so much less efficient to do it that way, but they don't know when they might get the next sum of money. So that's ideally, you just want to give a longer term funding settlement to an ICS, and therefore then they can spend it on reimbursing residential care homes when they have someone on a virtual ward within their care home. What's important with the health system in general is incentives, and making sure that if a residential care home knows that they would get paid for it, they're incentivized to have somebody under their care that's on a virtual ward. And inpatient care per day, probably it varies between hospitals and between wards, but you're looking at around £360 a day for somebody to stay in an inpatient ward. For a virtual ward, it could be around £90 running costs. So you're already at, like, just pure running costs, much lower. If you then wanted to put like a bumper incentive on that to the care home, say £30 a patient or something, you're still less than half of the cost of inpatient care. Like, it's completely affordable. And it's all of the incentives do exist in order to do it. It's just getting the funding model right and making sure they have enough money to do it. But like I say, everything in the health system, if you want to create certain types of activity, a lot of it comes down to how you fund certain things and the kind of incentives and activity that creates. And
Do
if
you
the government
feel?
want to create more virtual wards, sorry, go on.
No, just wondering, like, do you feel that a lot of the problems that happen in terms of there not being enough beds in hospitals and not being able to have enough capacity is to do with the funding model that there is, or is it mainly to do with management and the way that things are managed within trusts, or a bit of both?
It's both. So the way hospitals are funded, they're funded through two things. They're funded through a block grant, which is a sum of money that's allocated to a hospital that pays for emergency care. But they raise all of their income through elective care. So people that are on the elective backlog, people that need a hip replacement, or I'm trying to think of the type of elective care. Basically, somebody that needs non-emergency specialist care. That type of care is provided per activity. So the more activity they do, the more they get paid. So they're the only that's the only part of the health system that's funded on activity. And if you have an activity-based payment model, you incentivize activity, which means that all of the activity happens in hospitals because that's where all the money goes. So therefore, hospitals are incentivized to have more activity in their hospital because then they get more money. But also there are a lot of things that contribute to the kind of current corridor crisis in hospitals. And actually, the fact that people are on beds in corridors and then there's not enough beds in hospitals comes down to this idea of patient flow, which is how quickly you can get somebody in and out of the hospital building. And that's more complicated in the sense that a hospital is very interdependent. It's got lots of different functions and processes that rely on each other, like blood tests and wards and surgery and things like that. So it's basically, so there's like an efficiency question and how efficiently you're moving somebody through all of those functions. But there's also a payment question as to what kind of activity you're incentivizing in the health system. And just for context, the government have prioritised the elective backlog as their major target for this government. And the corollary of doing that means that you will have significantly more activity in hospitals, just because that's how you get down the backlog. So to answer your question, it's both how hospitals are run, but how they're funded, and the kind of activity that the funding model creates. I hope that was clear.
Yeah, no, that's really interesting. I don't really understand in that much depth, how the funding works. So I definitely learned something there. I want to go back to some of the work that you're doing at Reform Think Tank, and you've also looked at tech and social care. Is sensors in people's homes one of the major pieces of research you've done in relation to that? Or
Yes,
have you got
so
other things?
we did a paper recently on tech and social care, and this was fascinating. It was looking at how you roll out tech and social care and what the obstacles are, because we've come across loads of super interesting innovations that are kind of a win for patients, a win for the system, and a win for staff. Like particularly the sensors, they enable carers to kind of monitor the activity of individuals without necessarily having to be there. And actually, it's even better than that because it proactively flags when there might potentially be an issue with somebody in a way that you would never be able to replicate with human care unless you literally had somebody hanging out in the house all the time. And the actual potential of these sensors, if they're rolled out properly, is pretty enormous. But the problem with tech and social care is that it's kind of got this like curse of always being in pilot. So like local authorities will try it, they'll pilot it, and that's it. And they're just kind of perpetually in a state of pilots. There's the kind of procurement and funding flows. The procurement and the funding pots also work against tech. So to kind of procure tech in a local authority or kind of in any government environment, you need to make a very strong business case. Quite difficult to make a business case if you are an emerging tech company and your tool hasn't been used before. And like I say, they might have a few pilots here and there, but they might not necessarily be applicable, or they might not work for a particular business case. But essentially, the difficulty of the business case process really throws a spanner in the works for these emerging companies that might have these amazing solutions, but they can't pass these business case models that were designed for innovations designed like 30 years ago. They're not designed for like modern technologies. There's also like the funding pots for technology and social care are all over the place. They're really confusing, and they don't incentivize long-term funding. So like I say, they'll fund them for a year and then leave it because they don't have the fund anymore.
I think that's really
And then
interesting. Oh no, carry on.
no, long.
The only thing I was just going to interject there, because we did a locally, we looked at certain bits of tech that have been used locally, and we found it, and how care providers were using them and how they found them beneficial. There's things like the Wazan kit, but also not even just tech, it's also just processes like trusted assessors and going into hospitals and doing assessments. And that again, it was like, I like the way you framed it, perpetual pilot. That's exactly the same issue that people had, whether it was care associations. Our local care association was funding a few of those pilots, or if it's a grant that somebody gets from one of the funding bodies like Health Education England or something similar, and then it just ends, and then it doesn't go anywhere, and it's really frustrating because there actually are tangible benefits and there's evidence of that. But it is, so what you're saying is very much, I recognize it on the ground, what we're seeing and some of the stuff we've done locally. I wonder how that compares with, say, you've got a piece of tech in the NHS and something that helps a surgeon to spot a type of cancer or disability easier. Are their funding models a lot more straightforward compared to how you see it in social care, or you might not have covered that in your research as yet?
It's a good question. So business cases universally across the public sector are a huge pain. They're not really just, and then the principle of them is sound. Obviously, if you're spending public money, you need to be able to test if you're spending it on the right thing. Totally understand that. But the difference with the hospital setting is that clinicians in a hospital hold significant weight. And if a clinician is putting forward a business case, it gets a lot more traction. They have kind of a much more political power in a hospital setting, not least because they're the ones, they're the specialists, they're the experts. They can talk on behalf of all of the specialists and say, listen, I know what I'm talking about because I have to do these operations all the time. You don't quite have that equivalent in social care or any of those power dynamics in social care. So there's that's one major difference. Also, the kind of money you get in a hospital is kind of a different quantum to what you'd get in social care. Like, the funding envelope for one large hospital is about £1 billion. The whole of social care for last year, I think, was 28 billion. Bear in mind, there's like 1,400 hospitals in the UK, so the amount of money you could spend in a hospital setting is also quite different. There is so much less spare money available in social care, which really changes the business case process, or even just like the appetite for innovation, because they're so busy firefighting that they don't really have headspace to think about anything else. But generally, the business case is kind of business case process is kind of universally thought to be quite inadequate, and a massive pain for both sides. But yeah, the difference with there are a lot of parallels in the sense that in hospitals they also find it difficult to identify cost efficiency and cost effectiveness for a relatively new innovation. But you have different stakeholders that will boost it internally. And also there is a larger amount of money available in a hospital. Whereas in social care, it doesn't, like I say, it doesn't quite have the same dynamics between the different people proposing things.
So you've got the
Which,
double whammy of there not being a single strong voice within social care that can advocate for anything. And then you've got the other issue of there just generally not being enough money around per se to even invest in it. Do you feel like, because I know this government is concentrating on looking at cost efficiencies within the NHS, are you quite hopeful that those cost efficiencies, might be spread out across the system a little bit more? Or, how do you feel like trying to level out that funding disparity would actually help a lot of problems, funding more things in social care to help the
yeah,
NHS rather than putting everything in the NHS?
yes. So you can, like everyone in health policy will be saying that, will be saying if there is spare cash that's found, it needs to be moved into social care. The problem for social care is that they've commissioned the KC Commission, and that doesn't report technically for another like 4 years, I think it is. I mean, they've got the first report coming out next year, but I think they won't do anything on social care other than funding injections here and there until that report comes out. That's kind of the benefit of, that's why politicians kind of do these reviews sometimes, because particularly with social care, we know what the problems are. We don't need, like everyone will say, and this was exactly the same when the Casey Commission was announced. Everyone will say, we don't need that because we know what all the problems are. They've been well documented for over a decade. So, and it essentially means, like, in raw political terms, it means that they don't need to take really substantive action on social care until the report comes back, which subsequently means that if anything happens in social care over the next 5 years, if they do manage to find deficiencies in the NHS, it will come to social care in the form of kind of random funding injections and funding pots over the next 3 years. That's my prediction. I don't know if other people would agree with that. But I think realistically, looking at the political context, that's probably what it would look like. But it will be difficult to tell until the spending review.
Yeah, absolutely. And that's so worrying. It's so worrying for the sector to hear. But I do like your honesty. It's really, really refreshing. So you've done quite a lot of research looking at the inefficiencies and also some of the good practice within the systems. Is there anything in particular that you're working on at the moment that you're quite excited about, or is going to bring even more insights?
So a couple of things. So we're doing this Hospital of the Future project, which, like I say, really tries to think about what the Hospital of the Future should look like. When we interview people, we say, if you had to design a hospital for 2040, how would it look? So that's paper, we've got first paper coming out called Hospital as a Service, Not a Building. And that's all about how you take specialist secondary care outside of the physical hospital estate and provide it in a more cost efficient clinic effective way outside of the physical hospital building. So that's virtual wards, but it's also remote monitoring. It's breaking down the barriers between primary and secondary care. So that's that paper. Then we've got another paper on hospitals coming out after that, focused on patient flow. So the kind of points I was talking about with the corridor care, and how you get people through the hospital as quickly and effectively as possible without undermining patient safety, of course. Because hospitals, like I say, they're this convergence of loads of different functions and processes, and each individual patient will have a completely different journey. Like, I remember I spoke to a consultancy that was looking at this, and they analysed all of the patient journeys through the hospital over a year. I think for a patient profile of 170,000 patients, there was 260,000 different journeys through the hospital, all of them completely different. So it's really interesting trying to build a system that is capable of dealing with that. Then I'll have to check that fact though, but it was pretty astonishing fact. And then after that, we're doing social care. So that will be a really interesting piece of work. For that, we're doing 2 papers. The first one, well, we're likely to do 2 papers, it's not 100% certain, but it will be, first one will be kind of like a framing paper looking at methodically all of the problems in social care, but also doing kind of an international comparison. So looking at kind of 4 or 5 different models internationally and saying, like, looking at their funding model, looking at their delivery model, and looking at how other countries do it differently, because there are real variants across the world. And then the second paper will be how you deliver.
Well, that was going to be my next question. Are there any international comparisons that can be made, and could we take inspiration from anywhere else? But it sounds like that's something that you're going to be looking at and doing later on. And in terms of timescales for those papers on social work, are you thinking 2026?
No, they should be out. The first one should be out May or June time.
Okay, amazing. Oh, that's very quick. You must have a decent team, or just very efficient team to get those out.
Yeah, very efficient. We're only 10 of us at Reform, so in total, and in the health team, there's me and then 2 other researchers. But
Brilliant.
yeah, and we're working, because we work on local, we've got a team working on local government. We're actually doing the social care project as like a joint project between the 2, which is like a really nice convergence of the 2 work streams. And also it means we get to benefit from their local government knowledge, which is in itself a very complicated system.
It
So
is.
yeah, it's exciting.
Yeah. I actually like the way that you're working in that sense, because I think it's going to have a lot more people in social care are going to recognize it a lot more if you're talking about the whole system. You're looking at the funding as well, like how local government works, as well as not just explaining the problem in a bit more detail. I think that's going to be really helpful. And do you need anybody to interact with you to feed into that research, or have you done you pretty much know what you're doing and who you're asking and who you're going to for that?
If anyone wants to be interviewed for the paper, do reach out to us. We haven't started doing interviews yet. We're quite radical. We like to say a lot of the kind of unsaid, untold truths in the health system. So if you have a radical take, or even if you don't, and you just think you've got a good analysis of the problems going on at the moment, we want to hear it. If you have a really good idea, we want to hear it. That anybody that has like a unique perspective, or even just a really useful operational perspective on how social care works, then do reach out to us, because we're always looking to talk to interesting people. I think a big strength of our work is that we do a lot of interviews for all of our papers, and that really helps to clarify that we're going in the right direction. And often we engage with a lot of people we've interviewed when we're developing the policy recommendations, because it really helps to ensure that we've got the right idea, obviously, because these people have got, day-to-day operational experience of social care in a way that people working in a think tank don't, and it's important to be aware of that. So yeah.
Excellent. So there you go, people. You've heard it here first. Get in touch with Rosie and Reform Think Tank, and feed into their research, because they're all ears and they want to find out more about the sector and represent it the best way that they can. And just I find it really refreshing talking to you and your perspectives and how you look at the whole systems, and you're just not afraid to give an honest opinion based on the research that you've done. Do you who all think tanks are funded? Do you have a particular funding, or do you have to yourselves raise funding to do the work that you do?
It's a good question. So, like you say, all think tanks are funded very differently. Some have endowments, some have 2 or 3 very large donors. We don't have large donors. Like I say, we're a small think tank. We have a range of different sponsors. So we work with a lot of different corporations to produce different types of policy work. We work with small charities. So we raise our money. It's all on our website. All of the kind of our sponsorship and funding mechanisms. But a lot of our money comes from sponsorship. So that, like I say, will be partnerships with corporations that want to do certain types of policy work, whether that's in health or the civil service. And it's good. I mean, like I say, all funding models work well in different ways. This one's the way our funding model works is quite good, because it means we don't ever compromise our intellectual integrity through our funding model. because we literally can't, because we just have so many funders that it would be almost impossible to meet the demands of all of them. Not that all think tanks do compromise their intellectual integrity, but you have to protect yourself and your funding to ensure that you don't, or that there's no risk that it can happen. But yeah, to answer your question, we're funded by a wide variation of different corporations and charities.
Great. That's really interesting to know. And I wonder, so we've heard a little bit about how you want to interact with the sector. How do you feel you have impact with, say, policymakers? Obviously, you might do a report because you're working with a particular sponsor, but you generally have that ethos of how things can be done differently, and reform is in the name. Will you be trying to feed into the Casey reviews, or do you send your reports to policymakers, to ministers and their departments? Do you work at all, or have connections with the Department of Health and Social Care? How do you feed upstream, if you like?
Yeah, good question. So we do all of those things. We've fed into the 10-year plan. We'll feed into the Casey Commission. We speak to people in DHSC. We speak to people in NHS England. We also speak to people in MHCLG, which is the Ministry for Housing, Communities and Local Government. So, I mean, all think tanks really will be speaking to some politicians, whether it's the governing party or the opposition party or other parties. Um, uh, but you can get impact in different ways from that. So, a lot of the time you get a lot of your impact from talking to senior civil servants, because they're the ones that actually design policy. You can also talk to politicians about it, but obviously it depends on the politician you're speaking to. If you're not speaking to a minister, then politicians are often limited in how much they can do. Whereas if you speak to someone in, we speak to people in DHSC and NHS England as well. I think being a cross-party think tank as well is different, because you don't necessarily have a party affiliation, so you can't rely on that to necessarily always have influence, in the same way that maybe more explicitly Labour or more explicitly Conservative think tanks do. And that's a decision you make when you design a think tank, whether you're going to be cross-party or party. Technically, all think tanks are cross-party, I should say, and they would work with both parties, but they have a clearer affiliation than others. But it depends on what you identify to be as your point of influence, whether it's civil servants. I mean, in health policy, for me, influence is speaking to the leader of an integrated care system, hospital chief executive, as well as talking to a senior civil servant at DHSC or in NHS England or a politician. So it could be any of those 5 people I would consider influence, because you're changing policy somewhere, or changing a decision at some point. So yeah, it really varies. But yes, we send all of our reports to all of the relevant ministers and backbench MPs, as well as relevant civil servants, etc.
Excellent. That's so interesting. Well, I really felt like I've learned a lot from you. At one point I was taking notes and I thought, well, this is actually a live stream. I can just watch it back. But yeah, and people do watch it back. Somebody was asking, please, can you share all the innovations? So there's other people who are finding this really interesting as well. I think all your reports, I did put a banner up earlier. It's basically, I think you're quite transparent with sharing them on your website here. So I got this list by going to the research tab at the top, and then those lists came up, and presumably they all seem quite current. There's a couple from February this year, December, and I mean, you're really getting them out quite quickly. So presumably that's where people need to keep an eye out. Maybe there's a newsletter people can sign up to, or mailing list, is there?
Yeah, there is. You should be able to sign up to it on the website.
Brilliant. Okay. Well, thank you so much, Rosie. I've really enjoyed speaking with you. I think we've got through a lot in the last sort of like 45 minutes or so. Is there anything else that you wanted to highlight, or do you feel we've pretty much comprehensively gone through a lot of what you're doing at Reform Think Tank at the moment?
No, I think that's everything. Thanks so much for having me. It's been a really great conversation. I hope you got a lot out of it. I know I enjoyed it.
Yeah, no, definitely. And I think if you don't mind, we might be in touch when you have done those reports on social care, because I think that would be great to hear from you and maybe a colleague to deep dive into those reports. I think that's going to be really, really enlightening. And also it's something that I think people in different areas within can take to their ICBs or can take to their local authorities who might not be aware of the work that you're doing as well. So I think it's good to raise awareness with that. So yeah, thank you very much. Take care. And I'm
Thanks
just
so
going to
much
do
for
some
having me.
closing bits.
Thanks so much. Bye.
Bye. Great. Okay. So that was really, really good. I'm so sorry. My lighting is a bit funny at the minute. I feel like I've just got a halo. Just another reminder for anyone who hasn't actually joined us right at the beginning that we're going to be on Friday welcoming James Sage. We're going to be talking all things the Employment Rights Bill. Really important live stream. And it's going to be another one that I'm going to be taking notes probably instinctively on, even though I can just watch it back like everybody else. But I just feel like we just need to keep our ears to the ground and listen out for what's coming, because there can be some huge changes, I think, down the line on that one. And as always, please do subscribe and like this video, because the more that you like it, the more people see it. And this, we're just doing this pro bono. We're not sponsored by anyone to do these. So we're just doing it because we particularly want to raise the profile on certain things with social care. So do make sure that you do like and subscribe where you can, and reshare this live stream. If you're wherever you're watching it, just go up to the top bar where you put the websites in, copy it and email it out to your colleagues and get them listening to what Rosie had to say, and signing up to the other things that we're doing at Co-Produce Care. And also maybe you have a topic that you think you want us to cover or somebody that you want us to interview on here. I'd really appreciate it if you could just email us. We're at hi@coproducecare.com, and we are open. We've got quite a few live streams coming up. We're just confirming speakers, so there's a lot. I think we've booked people up until May at the moment, so it's very exciting. But yeah, we're all ears to find out if there's anything else that you want us to cover. And as always, we are starting with our Leadership Academy, a new 3-month course, and it's going to be more of a workshop. We're going to be doing peer-to-peer learning, and it's going to be CPD accredited as well. And we are going to be covering recruitment, retention, and employment law. So we will be having guest speakers, guest experts on that. And we've just put in the chat there where you can sign up to that. So do go into the chat of this live stream and make sure that you do click on the link, sign up and join us. We haven't got that many places for this. So we are, as soon as the places are gone, we're going to close this course. So it's going to be hugely beneficial to people. Peer-to-peer learning, along with having expert speakers, along with the workshop, is going to be really invaluable to people. We really want to help sort of small micro businesses who are doing care work. So please do engage with us on that. But otherwise, thank you so much for listening in to Co-Produce Care's live stream, and we will see you hopefully on Friday. Thanks, everyone.